In last 1 decade, there is a lot of progression in the diagnosis and therapeutic aspect of the all malignant tumors. Initially, we were classifying these all tumors based on morphology, and based on that, therapeutic decisions were being taken. Gradually, there was a role of immunohistochemistry, and in recent 5 to 7 years, there is a lot of development in molecular genetics to decide therapy and subclassification of the tumors.
So sorry to interrupt. Kindly make it full screen.
Yeah, just a minute.
Yeah, perfectly fine.
Fine. Okay. Head and neck squamous cell. I will focus mainly on head and neck squamous cell carcinoma. This head and neck squamous cell carcinoma is being classified based on different modalities. First and foremost is clinical findings, and based on its subside is classified in oral cavity squamous cell carcinoma, oropharyngeal, hypopharyngeal, and laryngeal squamous cell carcinoma. Based on morphology, it's divided into keratinizing and non-keratinizing. This keratinizing and non-keratinizing is very important to decide whether we should order HPV testing or not. If it is non-keratinizing, there is high probability of it being HPV positive. So this morphological subtype is very important. Based on mutational analysis, there are two main types, HPV positive and HPV negative. In HPV negative also, there are two main subtypes, which is copy number alteration silent. Alteration silent means in this subtype of HPV negative, there is not much copy number alteration, whereas other subtype is copy number alteration high tumor. In this high tumor, there is a lot of variations in the copy number alterations. Then based on gene expression profiling, this squamous cell carcinoma of head and neck is subclassified in the atypical type, basal type, classical type, and mesenchymal type. And based on his immunoprofile, whether is immune active, means how much inflammatory response, host inflammatory response is there. If it is very high, is considered as an immune active type. And if there is not much inflammatory response, it's known as immune exhausted type. Even though it's a little bit theoretical, we will see more of molecular findings, genetic abnormality, and this subclassification in a little bit detail. There are a lot of genes which are involved in carcinogenesis of head and neck squamous cell carcinoma, and based on its function is classified broadly in 4 categories. First is cell survival and proliferation. If there is a mutation in TP53, EGFR, PIK3C, and HRAS, there is high proliferation. Cell cycle controller. These genes control the cell cycle, whether it remain in the proliferation phase or static phase of the cell cycle. Two most important gene of this category is CDK and 2 and CCND1. CCND1 is IAC counterpart is cyclin D1. Third one is cellular differentiation, which stage of differentiation this tumor will go. This is decided by some of the genes. One of these is Notch1. Then cellular adhesions and invasive signaling. If there is a deficiency in cellular adhesions, there is high chances of it being more infiltrative tumor and more spread of tumor. One of gene is FAT1. Apart from this gene, there are other genes like NSD1 and Ajuba also involved in carcinogenesis of head and neck squamous cell carcinoma. This is a broad category of classification of head and neck squamous cell carcinoma. In this category, apart from morphology, is etiology like aging, smoking, immune profile, everything has been incorporated in this classification. We'll see one by one in little detail. First is HPV positive tumor. If we see, first category is HPV positive tumor and HPV negative. In HPV negative tumor, most are atypical type. In HPV negative tumor, I told copy number alteration silent and copy number alteration high. Copy number alteration high itself is divided in 3 broad categories: basal, mesenchymal, and classical type. See, HPV positive tumor usually lacks mutation in TP53 and CDK and 2A compared to HPV negative tumor. This tumor has a high probability of PIK3CA mutation. PIK3CA mutations This is at present is being used in breast and other malignancy, but not therapeutic targets for this three. This PIK3CA is not available for routine practice for head and neck squamous cell carcinoma. One thing I want to make it clear that PIK3CA mutation detection by RT-PCR misses some of the mutation. Best technique is droplet digital PCR. This tumor also displayed loss of TRAF3 gene and amplification into F1. T2F1 is very important in HPV positive tumors. If we see gene expression profiling, these are usually atypical phenotype, and based on immunoprofile, this is immune active type. So HPV positive tumor are more susceptible to anti-PD-L1 treatment as compared to HPV negative tumor. Based on RNA sequencing data, these HPV positive tumors are divided further two types. IMU means in this there is a upregulation of the genes involving mesenchymal differentiation and immune response. Second is HPV KRT type. KRT type, these tumors are enriched for genes involving keratinocyte differentiation and oxidative reduction processes. HPV negative tumors, there are three main abnormality. Amplification of the receptor tyrosine kinase like EGFR, which is very important when you want to decide cetuximab therapy. Deletions in tumor suppression gene like Notch1, SMAD4 and FAT1, and alteration in oxidative stress regulator like KEAP1 and CUL3. Subtypes of HPV negative types, copinoma alteration silent type. This tumor is different from other subtype of HPV negative tumor in that this is P53 wild type tumor. So there is a less probability of getting P53 mutation on molecular. There is high probability of mutation in HRAS and Cas8 gene. These tumors are MMR proficient. In general, we find less MMR instability in head and neck squamous cell carcinoma. Majority of head and neck squamous cell carcinoma are MMR proficient. These tumors are mainly seen in female patients without any history of smoking and alcohol. So this is not HPV positive tumor. This occurs in a female patient without any history of alcoholism or smoking. So what is the etiological factor? What study says that many are due to because of aging, and that aging causes abnormality in genes and causes a head and neck squamous cell carcinoma. Second category of HPV negative CNA is CNA high tumor. These are usually associated with smoking and tobacco chewing, and this display DNA abnormality and DNA damage repair pathway gene. So it's like BRCA1, BRCA2 abnormality and abnormality in double-stranded break repair mechanism. So in future, drugs against these targets, BRCA1, BRCA2 may be helpful in treatment. Based on gene expression profiling, 4 types: atypical, basal, classical, and mesenchymal. Atypical is majority are HPV positive. There will be activating mutation in PIK3CA. This is a future target for PIK3CA therapy. There will be lack of mutation in the amplification in SOTAMOP7. SOTAMOP7 is a region where EGFR are located. So if in view of because of abnormality of amplification, there will be low expression of EGFR. So this tumor may not benefit with the anti-EGFR cetuximab therapy, which is currently available. Basal type displays abnormality in Notch1 and RAS. It's not currently helpful in treatment. Mesenchymal type, this shows modification in immune-related gene, higher expression of CD50, low frequency mutation in HLA. Classical type, important is there is a mutation in TP53 and CDK and 2A. Now, based on which side these tumors are, whether it's oral or non-oral, there is a different predominance of different genetic subtypes for based on different side. In oral squamous cell carcinoma, basal and mesenchymal type is common, whereas in non-oral like oropharynx, atypical. Atypical means more of HPV positive is common with high immune response and PD-L1 response. Based on immune profile, there are different ways to classify based on immune profile. If we see CD8 positive T cell, if that infiltrate is high, it's called as T cell inflamed phenotype high, and that inflammation is low, then it's known as TCIP low type. This TCIP low type has a higher amplification of EGFR, so that maybe this tumor may respond to cetuximab. Based on immune class, this Chan et al. Divided this tumor in immune active and immune exhausted. Immune active have a pro-inflammatory immune signatures, means pro-inflammatory M1 macrophage are more in these tumors with abundant tumor infiltrating lymphocyte. Because of this more inflammatory cells, there is heightened cytolytic activity, and this tumor responds very well to PD-L1 blockage, anti-PD-L1 therapy. This immune exhausted type, there is less of immune response, whereas more of stroma, desmoplastic stroma is more in these tumors with anti-inflammatory type of macrophages profile and poor survival. If you see the gingival-buccal squamous cell carcinoma, this is caused by tobacco chewing and betel nut chewing in and Asian subcontinent, and this tobacco chewing causes triggers abnormality in some of genes like Notch1, PIK3CA, and these together causes a carcinogenesis. There are some specific genes which are seen only in tobacco chewer in region of gingival-buccal squamous cell carcinoma, like ARID2 and USP9X. In Chinese population, instead of tobacco, there is a habit of chewing areca nut. In areca nut chewer, there are different genes which are involved in carcinogenesis, like ATG2A, V1. There are experiments going on for therapy against anti-V. This anti-V therapy is under trial. These tumors have high abnormality in mismatched repair genes. The genomic deficiency has been reported, and there's elevated PD-L1 expression. So this tumor responds to anti-PD-L1 therapy. Apart from this genetic abnormality, epigenetic modification in the gene also is responsible for head and neck squamous cell carcinoma, like hypermethylation in promoter of P16. This causes inactivation of P16 and is responsible for oral squamous cell carcinoma. These are the some of the genes which are being studied or in the clinical practice. Very few are available in the clinical practice, like cetuximab, anti-EGFR, nivolumab, and pembrolizumab, anti-PD-1. Rest of all drugs are under clinical trial and not being used in clinical practice. Apart from this PD-L1 therapy, some of mutation causes are responsible for resistance to some of treatment, like CTTN mutation is responsible for resistance to gefitinib. CCND1 mutation is responsible for resistance to cisplatinum. So if we ask for NGS therapy and patient is not responding to this cisplatinum and we get CCND1, we can predict that response to cisplatinum may not be good in this patient. Now, little bit detail in anti-PD-L1, only 5 minutes. Almost 50 to 60% of head and neck squamous cell carcinoma overexpress PD-L1. If we see only tumor cells, that is TPS, tumor proportion score is only seeing 50 to 60% of head and neck squamous cell carcinoma overexpress PD-L1. But if we involve immune cells also, nearly 85% of squamous cell carcinoma has overexpression of PD-1 either in tumor cells or either in immune cells. So that is known as combined positivity score, CPS. How we report PD-L1? As I told, TPS is percentage of tumor cells, viable tumor cells with the staining, and if we add immune cells also, we combine these two, is known as CPS. Total number of tumor cells and immune cells with staining for PD-L1 is CPS. We also have to mention ideally immune cells positivity, which how much of tumor area being involved by immune cells. regarding which clone to be used, there are two main company clone are available, Daco and Ventana. Daco 22C3 and Ventana SP263 both gives nearly good results for therapeutic purpose. It is only the cutoff which we use. There are reports that even though patients are positive for PDL1, they don't respond to anti-PDL1 therapy. So apart from PDL1, there are other molecules in tumor microenvironment which is responsible for deciding factors for response to immunotherapy. One of this is PD2 and second is CTLA4. There is ipilimumab is under a trial for treatment in head and neck squamous cell carcinoma. Second is tumor mutation burden. How much tumor mutation burden is there in tumor, which also predicts response to treatment and prognosis. Last proportion of head and neck squamous cell carcinoma, high TMB, and usually seen in patient with heavy smoker and presence of HPV or EBV infection. And this tumor has, as I told, higher T cell response. So this tumor also responds very well to PDL1 therapy. But this TMB and PDL1 are independent, not interrelated. Microsatellite instability. This micro instability is low in keratinizing or HPV negative squamous cell carcinoma, except in HPV positive squamous cell carcinoma. Little bit about how we assess HPV status. We can do screening by HPV ISC if more than 70% tumor cells show diffuse moderate to strong nuclear cytoplasmic staining is considered positive. Apart from ISC, two types of ISH are available, mRNA and DNA ISH, and two types of RT-PCR, DNA RT-PCR, RNA RT-PCR are available. So P16 ISC is positive and tumor is non-keratinizing type, we can consider is positive. If tumor is keratinizing type, because keratinizing squamous cell carcinoma is usually HPV negative. So we have to further check this P16 staining. If RT-PCR or any molecular technique is positive for HPV, it's considered HPV positive. And if molecular technique is negative, we should consider it's negative. If P16 is negative and tumor is keratinizing type, we can leave it as a HPV negative tumor. But if tumor is non-keratinizing type, then we have to do molecular testing. If molecular testing is positive, we should consider this a HPV positive tumor. In all equivocal cases, we have to do molecular testing, and if it is positive, we should consider positive for HPV. So there's a lot of role of molecular in the future, and probably many drugs which are under experiment or trial may come in clinical practice. Thank you.
Thank you, Dr. Sanjeev Shah, sir, for your excellent lecture. After this lecture, we are entering into our first session, that is neoadjuvant chemotherapy in head and neck cancer. For that, I would like to invite Dr. Kaustubh Patel, sir, as a chairperson. He is a senior professor and director in Department of Head and Neck Oncology, SCG Cancer Center, Ahmedabad. Over to you, sir.